So today I want to finish off your educational year with a little bit of heresy, if you will. Heretical on 2 points. One, I swore to myself I would never do PowerPoints of these talks ever again, because it's not really the right format for that kind of thing. And second, because I'm flying in the face of all received wisdom about the wonderfulness of para and the importance of resident advocacy. But consider this. An 82-year-old lady shows up in an emergency department. She's agitated, she's delirious, tachypnic hypotensive, she's got lactic acidosis, and she's getting sicker. Despite everything that's been going on, they've given her fluids, they've given her pressors, she's in refractory shock. Well, what do? What's wrong with her? So, you've seen this kind of talk before, right? They give you a case, walk you through a whole bunch of things, you throw out a bunch of ideas, a bunch more comes to you, and eventually you come to some conclusion, right? But the problem with medicine is that often what we do is very poorly defined. Right? We have incomplete information. I didn't give you nearly enough to go on with that data. And on top of that, time is usually a factor. You have, this lady is clearly getting sicker, and you probably don't have you're having a closing window of opportunity to do something before it becomes irreversible. But that's how we teach people, where we make it very stepwise, ask questions, and it seems like the only time pressure we have is to get this done before 8:30. So we have lots of time. And it is true that education is effective when it's much more effective when it's case-based, and when we have a defined problem. And then I give you clues throughout the course of it to get you to that answer. And that is an effective teaching style. Because what we often want you to do out of this is generate a differential diagnosis. And in that differential diagnosis, I don't know what your base training is, but when I was training in internal medicine, whoever could come up with the biggest, longest differential diagnosis was the smart one in the group. Although now more recent studies in cognitive psychology would suggest actually that's not actually the case. But anyways, once you have, that's the clinical teaching that we do, but then your independent teaching, we just say, go read, go just sit there and read Harrison's. That was what I was told. Read Harrison's cover to cover, and you'll be ready for your internal medicine exam. Yeah, that was, have you seen Harrison's? Yeah, I had two choices. I could have a relationship, or I could read Harrison's. I'm happily married, so I guess you'll know what I did. Well, in reality, cognitive psychologists have come up with different models for how experts make decisions under time-pressured scenarios. And one of the most common ones is a model called the recognition prime decision-making strategy model. Has anybody heard this model before? No. It's a shame it doesn't come up, because it actually, to me, seems to be the way in which most people think. This is a model developed by Gary Klein, a psychologist in Idaho, who went through. I think he did this mostly because it would be a really fun way to do a study. He went with firemen, and he said, "I want to know how firefighters make decisions. It's time pressured. Every scenario is different. It's decision making in a natural environment, so naturalistic decision making." So he went on all these trips with firemen. he got to stay at the firehouse, and then the alarm would ring and he'd get to slide down the pole, and can see the appeal of the study. And he would, as the fire chief would hop out of the car, he would see the fire, he'd have to start directing people, and he'd have like minutes to make all of these massive decisions. And the traditional thinking at the time was experts would make decisions by coming up with a list of possibilities and picking the best one. And certainly, at some point in time, that's what you've been told, that you come up with a list of possibilities and you pick the best one. And that's what I was told. Generate the long differential diagnosis and pick the best one. And I was really feeling guilty for many years after I was in practice, because I wasn't really doing that. And I thought, I must be the worst doctor ever, because I'm not doing what they told me to do. And then I learned about a guy who got to go as a psychologist on fire trucks and discovered that maybe I wasn't the worst doctor in the world. Second worst, maybe. But in his study, he discovered that not only did firemen not make decisions by picking the best of the options, they picked the first option that came to their mind. Which, of course, you would think, well, that's madness. I mean, the first thing random thought that popped in your head, and you just went with that? Like, that's craziness. But it was often the right one. Because he would review the scenarios with other fire chiefs, and they would often say, yeah, that sounds like what I would do. And he would also talk to them when there was unexpected events and say, why did you do what you did in that unexpected event? And the answer would always be, well, because it just seemed like that's what I should have done. I mean, I didn't come to a conclusion. I didn't consider all of my options. I just did what I thought I should do. So we developed this model by exploring their thoughts as they would go through these scenarios. And he came up with a model called recognition prime decision making, basically meaning whenever you make a decision, you make that decision based on what you know, what you've seen in the past, and then you model it, and then you implement. So the steps he would go through is he defined it as a number of steps that we do in our heads. He would say, well, first you experience the situation. So the phone call, the patient downstairs, 81-year-old, delirious, deteriorating patient, changing context, sounds like a very familiar context, but maybe a little different. First question you always ask yourself is this a typical situation? Is this what I've seen before? Do I recognize it? The answer is yes. Recognition requires several different aspects to it. So expectancies, what will I expect to happen as a result of this? What are the relevant clues that come with that recognition? What are the possible goals I could have, and what actions do I need to take as the next steps? So you run through all of this. It comes up with a typical situation. It seems like it matches. You know what the next step is going to be. So then in your head, you run a mental scenario, a simulation of how will this go? This 82-year-old who's delirious, whose blood pressure's falling, who's got refractory shock. Well, what if I do a certain thing, if I perform an action on it, what will I expect to be the outcome? When you first see her, before the fluids are given, before the vasopressors are given, your action is, I'm going to give her fluids. She's probably dehydrated in some way. There's some part of the story we don't know. She's probably dehydrated. I'm going to give her fluids. I expect to see that her blood pressure will go up. So I give her that, and I test that hypothesis. Now, before you give the fluids, before you actually do it, you run that simulation, and you ask yourself, well, do I think it will work or will it not? And if the answer is no, then you go back and you come up with your next action, right? And you run through that list. But if you, as you're doing this, you're also looking for your expectations. What do I expect is going to happen? If I give her fluids, I expect that her blood pressure will get better. I gave her fluids, and it didn't get better. Well, then there's an anomaly that I have to explain. So that often means you need to clarify it, find out, okay, why didn't that happen? Was it something that we did? Is the IV interstitial? Is there something wrong with this? I'll make that diagnosis and then go back and start it over again. If it seems like there's something more of the story that's missing, then that's when you need more data and you go back right to the beginning and you start all over again as well. So for the firemen, fire chief's context, for example, firemen would jump out of the car, look at the fire and go, I've seen this type of house fire before. It looks like it started in the kitchen, probably a grease fire. So I expect it to be a grease fire, I expect it to behave in a certain way. Take a couple of actions, direct a couple of fire teams to, contain on this side and start a search and rescue on this side. Before he gives those orders, he think, okay, so in the kitchen, if it's in the kitchen and everything is going, and I'm going to do this, will I expect that I'm going to get containment, or is the fire going to go out of control? Well, if it's a kitchen fire, probably is controllable. So evaluated it, ran a simulation. Will it work? Yep. Go ahead. Done. Decision's all made. Everything's done. We've got a plan. Let's say he's inside the house. He sees the kitchen fire, but there's something not quite right about this fire. It's hotter, or it's quieter. And these are not normal. I mean, I'm not a fireman. I don't know what those mean, but there's something anomalous about this. And so the fireman will go back and start saying, well, there's something fishy here. What's going on? I'm going to get more information and redo this. And the amazing thing is we make all of these, that thing works like that, automatic. Like these things are occurring in milliseconds in your head. You're not actually consciously doing these. And so this is something that requires expertise. So how do you know an expert when you see one? Because not everybody's an expert, right? I'm not an expert at orthopedic surgery. Tom is, right? He just left the room and probably to go fix somebody's bone. I don't know how to do that. Right? But there's a number of things that experts have that novices don't. One, novices don't recognize patterns. They don't see things that they don't quite appreciate that this has happened before and will happen again. Experts do. And when I say experts, I don't mean that you have to be the Dr. Gibneys of the world, the well-experienced, senior physician, clinician, expert. You don't. You just have to have seen a lot or done a lot. That's what makes you an expert. An expert is able to pick up anomalies. This story doesn't quite fit. There's something wrong with this. It's not what I expected. And that matters to them, and they will seek more information as a result. Experts are much better at seeing the big picture. So that's why you want in a code, that's why you want the code leader to not be involved in all of the little things, but actually looking at the big picture. Ideally, the code leader is the most experienced physician in the room at the time. They're the ones who have the most expertise. At 2 o'clock in the morning, that could be you, and in fact, you may actually be the most experienced person in the room at the time. And that makes you an expert of sorts. And also understand the fundamentals and the way things work. So you don't have to be a biochemist or a physiologist, but an expert has an intuitive knowledge about how things work. They know that a salicylate overdose isn't just a pattern of respiratory alkalosis with metabolic acidosis. An expert knows that salicylate specifically binds to receptors in the respiratory center and increase its drive. They also know that salicylates will poison the electron transport chain and can cause a lactic acidosis from a disconnect of oxidative metabolism. He doesn't have to know which protein it is, but he knows more detail about it. Has a much more deeper understanding of the fundamentals of how things work. They also have the ability to improvise on the fly. So something isn't quite meeting their expectations, something's quite different, and they can improvise with it and come up with a different solution to the problem, and can predict how things are going to go. So I met my first dyed-in-the-blue expert when I was a first-year fellow. My staff on at the time said, we had a patient who was in shock and looked sick, and it looked like sepsis, and I said, Sue, I got it. I'm going to take care of this patient. Don't worry. You go have supper. I'll let you know how things are going. It seems like just a septic shock, and I'm on it. Cocky little junior fellow trying to run the show here. Her answer was, okay, I'm going to go grab a coffee, and I'll be back in about 15 minutes or so. And she said, in 15 minutes, you're going to probably need me. And in 15 minutes, I sure needed her. Because what she recognized was that the patient actually had the double problem of a poorly compensating heart and septic shock, which was a pattern I didn't recognize because I was new. But she knew it, and not only did she know that that was a pattern that she recognized, she also knew how that was going to play out, so she knew how long to let me dangle, but pop back in just at the right moment to help drive the point home. It wasn't that you left the patient suffer, but you wanted to make sure I had the opportunity to try to figure out why the pattern wasn't working and then demonstrate the rationale for why it wasn't. Because they are able to notice the differences, the small differences that novices don't notice. Okay? That's the key. And they also know their own limitations. You probably notice that a lot of senior clinicians will often say, beats me, we're going to get a consult. We're going to get ID to see them. We're going to get ortho to see them. We're going to get somebody else here. This is way outside my knowledge base. Most of these skills come from pattern matching and mental simulation. So the ability to say, I've seen this pattern before and I recognize it, and I've done enough of these enough times that I know how this is going to go. So, how do experts learn? Number one, engage in deliberate practice. So they see a lot of things and they do it in a very practical, deliberate, everything they do is thoughtful. I'm going to this fibula fracture. I'm going to be very pedantic and go through all the necessary steps to fix this in the way that I was traditionally taught, and I want to make sure that I reach that goal, that I've done everything I need to do, and make sure that I've done it well. So it's deliberate practice. Okay? They come up with an extensive experience bank. That's what makes the difference between an expert and a novice is practice. And they get feedback. And they get accurate feedback. Nobody's doing you a favor if they say, yeah, you're fine. Yeah, fine, yeah. And you're definitely not doing yourself a favor if you accept that. Or worse, my evaluation didn't make me seem like I'm the wonderfulest person in the world, and he said some harsh things like I needed to read more. Awful doctor. He's trying to help you, or she's trying to help you by giving you some feedback to help you learn and become an expert. The problem with a lot of the challenge with a lot of the evaluations that you see are they're not really timely. This is actually a very important thing because what's happening up here is you're forming connections, you're seeing new experiences, and you're forming connections and you're developing patterns. Neurons are forming their little dendrites and axons are going out all over the place, forming connections. And unless you get feedback on what's right and what's wrong, you will set wrong connections. Feedback is critical. Okay? And then they go back and they review. They review and they review and they review. They go find out what happened to the patient, and they read about the patient, and then they think about that patient later on and go through their head, okay, I did this, and that seemed to work. What could I have done differently that would have made this better? If that worked, that's great, but that didn't work, so why didn't it work? Like really just spend some time thinking about it. It doesn't have to be a formal debrief. It doesn't have to be, it doesn't have to be anything simpler than just simply telling a friend about it. Telling a colleague, oh, I had this really tough case, and let me tell you about it, and get some feedback from them about what they think you could have done differently. Or just tell them the story and hear them say, yeah, that sounds cool. That was really neat. Because when you tell a story in your mind, your mind doesn't know the difference between you telling the story and experiencing the story for real. You form stronger connections the longer you tell it, the more frequently you tell the stories. So continue to review what you've done. And to be fair and to be clear, I actually don't hate para. I just use that to get your attention, because it's much easier to say striking and scary things to get everybody's attention and to focus. But the point I was also trying to make is work-life balance is critical. You need to have adequate sleep. And that's something that Gary Klein doesn't get into, because obviously it wasn't part of his study. But you need to actually get proper sleep and rest in order to get the maximum benefit out of your experiences. But you actually have to have experiences. So the more you cut into your clinical exposure, the more time you don't see things, the harder it's going to be for you to obtain that level of expertise. So it's not that para is doing anything wrong. In fact, I was a para resident at one point in time. I was a resident in Alberta. I benefited from all of the things that they've done. And I'm not saying that they're doing anything wrong. I don't disagree with a lot of the things that they do, but be careful that you don't take it too far and say, my rest is more important than my experiences. Experience really matters. And as much as we would like to think that medicine is a academic, cognitive discipline, it is actually a bit more like an apprenticeship, where you just have to see a lot. And the more you see, the more you learn, the better you are, and the sooner you're an expert. And that's all I've got for you. That's the last talk for the day, for the academic year.